Hello, everyone. Hope you're all having a good day so far. Welcome to episode 13. Can you believe it's already December? I know I am ready, more than ready, to see the end of 2020. It's been a challenging year for us here. Well, a challenging year for everyone worldwide. Today is Wednesday, December 2nd, 2020. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. Now, CPT changes take effect January 1st, 2021. That's only 30 days away. Are you ready for the biggest E&M changes in 25 years? Well, I get into it in this episode. This episode highlights the newsworthy E&M changes coming up in just 4 weeks and my coordinating trusty tips on medical decision-making, or MDM, and time. And I also share some wise words from Brazilian author Paulo Coehlo. If you checked me out on LinkedIn, you know I'm all about compliance and protecting our physicians and valued healthcare professionals when it comes to the business of medicine. I hope this week with me brings you enough to take back to your organizations, to want to dive in deeper, to use my tips and best practices to ensure success. I hope this podcast will help you boost quality of documentation capture and improve coding accuracy as you help your providers paint the medical picture. If you like what you're hearing, go ahead and hit that subscribe button now so you don't miss an episode. Please write in a review and rating on Apple Podcast or wherever you listen to my podcast. I'd really love your support. Now, a quick disclaimer. Before I get started on the episode, this podcast episode and Nexsen Pruet podcast series do not constitute legal advice, but I am fortunate to work with the sound healthcare attorneys at Nexsen Pruet, and as their consultant, I have over 10 years of experience in front office, back end, coding, and billing for multi-specialty physicians, compliance, and auditing for both E&M and surgical operative reports. Again, the opinions and insights throughout are mine alone, and they in no means constitute legal advice. So, let's get into Newsworthy. In my first episode, I briefly discussed the sweeping changes made to the traditional evaluation and management, or E&M, office and outpatient visit codes we have been so accustomed to for 2 decades in the 95 and 97 guidelines. The American Medical Association, the AMA, CMS, the MACs, basically everyone, has continued to advise physicians and healthcare organizations to prepare early for the January 1st, 2021 implementation date. But, as I said, it's already December 2nd. Remember, the intent behind these changes is part of the Patients Over Paperwork initiative to assist our providers in focusing instead on quality patient care and decreasing their stress levels and burnout. Patients Over Paperwork aims to decrease administrative tasks and high volumes of note bloat. Remember, the new E&M major changes include eliminating number 1, CPT code 99201 for new patient. Number 2, eliminating the history and physical exam as criteria for code selection. And number 3, code levels are instead chosen by medical decision-making, or time. So then, the focus of new E&M major changes is solely on CPT codes 99202 through 99215 for both new and established patients in the office or outpatient setting only. It's the medical documentation that has been the sore spot for the old 95-97 guidelines. And it's the new 2021 medical documentation that will again be reviewed and leveled and then later audited. So it's imperative that you understand that medical necessity is still and always will be the driving factor. Simply because history and physical exam components will not be scored by auditors does not mean that you should not be capturing relevant, pertinent patient history and physical exam elements assisting in medical decision-making. To be clear, history and physical exam will still need to clinically be relevant. You still need to paint a clear, rich, vibrant medical picture in 2021 that focuses on MDM and time. And now it's time for my best practice tips in Trusty Tip. So let's get into medical decision-making, the MDM, for 2021. There are 3 subsections that make up MDM in 2021. The first subsection is the number and/or complexity of problems addressed. The second is for the amount of data and/or the complexity of data to be reviewed and analyzed. The third subsection is for the risk of complications and/or the morbidity or mortality of patient management. It's important to recognize that both new and established patients are scored the exact same way. Bonus for us auditors, for sure. It's also important to recognize that 2 out of the 3 MDM subsections must be met to use MDM as the level for coding. The levels are still the same we are used to in name from 1995 and 1997 guidelines. These levels are still straightforward, low, moderate, and high. When looking at subsection 1 for the number and/or complexity of problems addressed, look at it this way. So for either new patient 99202 or established patient 99212, there must be 1 self-limited or minor problem. This is equivalent to straightforward MDM. And for either new patient 99203 or established patient 99213, there must be 2 or more self-limited or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness or injury. This is equivalent to low MDM. And for either new patient 99204 or established patient 99214, there must be 1 or more chronic illnesses with exacerbation, progression, or side effects of treatment, or 2 or more stable chronic illnesses, or 1 undiagnosed new problem with uncertain prognosis, or 1 acute illness with systemic symptoms, or 1 acute complicated injury. This would be equivalent to moderate MDM. And finally, for either new patient 99205 or established patient 99215, there must be 1 or more chronic illnesses with severe exacerbation, progression, or side effects of treatment, or 1 acute or chronic illness that poses threat to life or bodily function. This is equivalent to high MDM. Now, moving on to subsection 2 for the amount of data and/or complexity of that data to be reviewed and analyzed. Let's look at it this way. For 99202 or 99212, there is minimal or no data. But for the others, 99203 through 99215, there are now 3 categories, categories 1, 2, and 3, that will vary based on if you're reviewing criteria of limited, moderate, or severe. So that sounds confusing, but let's break that down even further. For limited, this would be equivalent to your 99203 or 99213 and must meet at least 1 of the 2 categories. These are, generally speaking, the more ordinary types of services associated with the average patient interaction that could include ordering tests, reviewing tests, review of external records. This is category 1. You must meet 2 of those 3 to use category 1. So you must meet either ordering the test or reviewing the test or reviewing of external records. So you have to meet 2 out of those 3 to use category 1. Or for category 2, which is obtaining history from someone other than the patient. Now for moderate, This is equivalent to 99204 or 99214, and you must meet at least one of 3 categories. Category 1, again, includes ordering the test, reviewing the test, review of external records, but it also includes obtaining history from someone other than the patient, which, yes, I just said it earlier, it is the Category 2 for 99203 or 99213. You must meet 3 of those 4 to use Category 1. Or Category 2, which is an independent interpretation of a test performed by another physician or other qualified healthcare professional, and that's not separately reported. Or Category 3, which is the discussion of management or test interpretation with an external physician or other qualified healthcare professional or appropriate source. That's also not separately reported. And then for extensive, this is equivalent to 99205 or 99215 and must meet at least 2 of the 3 categories. This level is the same as moderate, but you must meet the specifications of 2 categories out of the 3. So again, Category 1 is for including the ordering of the test, reviewing the test, review of external records, but also includes obtaining history from someone other than the patient. So you must meet 3 of those 4 to use Category 1. Or in Category 2, which is for independent interpretation of a test performed by another physician or other qualified healthcare professional that's not separately reported. Or for Category 3, which is your discussion of management or test interpretation with an external physician or other qualified healthcare professional or appropriate source, that's also not separately reported. And when you're looking at subsection 3 for the risk of complications and or the morbidity or mortality of patient management, let's look at it like this. For 99202 or 99212, there is minimal risk of morbidity from additional diagnostic testing or treatment. For 99203 or 99213, there is low risk of morbidity from additional diagnostic testing or treatment. For 99204 or 99214, there is moderate risk of morbidity from additional diagnostic testing or treatment. 2021 provides you with examples such as prescription drug management, decision regarding minor surgery with identified patient or procedure risk factors, the decision regarding elective major surgery without identified patient or procedure risk factors, or the diagnosis or treatment has significantly limited by social determinants of health. So for your 99205 or 99215, there is a high risk of morbidity from additional diagnostic testing or treatment. 2021 also provides you with examples, specific examples such as drug therapy requiring intensive monitoring for toxicity, decision regarding elective major surgery with identified patient or procedure risk factors, decision regarding emergency major surgery, decision regarding hospitalization, decision not to resuscitate or to de-escalate care because of poor prognosis. And finally, let's dive into time for 2021. Time has changed as well for 2021. 95 and 97 guidelines were all about face-to-face time and activities spent with the patient. But new for 2021, changes include non-face-to-face work as well. Time is also an option whether or not counseling and coordination of care is the main player in an encounter. So the AMA has given you examples like reviewing tests in preparation for a patient's visit, document that time. Counseling or educating a patient, family, or caregiver, document that time. Reporting test results to a patient by phone, report that time. ordering medications, tests, or procedures. Report that time. This is pretty funny. They also write down pajama time documentation work performed at home, right? Since we are living in the age of COVID right now. So they want you to go ahead and document that time, that extra work you do at home. Any work that you do at home, document it. This is a true example that the AMA has documented well. Further, 2021 provides time thresholds that must be met if you want to level your codes based on time. So for your new patient visits, 99202 must be for 15 to 29 minutes of total time spent on the date of the encounter. And again, total time means document that face-to-face time with the patient and also document that non-face-to-face time as well. Those two elements comprise total time. 99203 must be for 30 to 44 minutes of total time spent on the date of the encounter. 99204 must be for 45 to 59 minutes of total time spent on the date of the encounter. 99205 must be for 60 to 74 minutes of total time spent on the date of the encounter. And for your established patient visits, 99212 must be for 10 to 19 minutes of total time spent on the date of the encounter. 99213 must be for 20 to 29 minutes of total time spent on the date of the encounter. 99214 must be for 30 to 39 minutes of total time spent on the date of the encounter. And 99215 must be for 40 to 54 minutes of total time spent on the date of the encounter. As always, document all of this face-to-face and non-face-to-face time for each activity. Remember, by painting a true and honest medical picture that drives your medical decision-making, you are in fact proving the medical necessity for each and every patient encounter at your office. Your certified medical coder can then abstract codes with accuracy. And finally, this week's inspiring quote in Spark is from Brazilian author Paulo Coehlo. When we least expect it, life sets us a challenge to test our courage and willingness to change. At such a moment, there is no point in pretending that nothing has happened or in saying that we are not yet ready. Of course, I find this quote to be utterly remarkable in our current time. Life has given us massive challenges with the coronavirus pandemic. I believe we all have pivoted, keeping change front and center. No one here is burying their heads in the sand, pretending all is normal. We are all aware moving forward that we are going into a new normal. This is our new normal. I know I am grateful here in healthcare for the many accomplishments we have made during this time of the COVID-19 pandemic. I am happy Paulo Coehlo's spark still burns brightly in all of us today. So, that wraps up today's episode. Please make this a great day, a great week for yourselves. Aim a little higher and give more of yourself if you can. I appreciate you diving into today with me. And if you would like to inquire about my consultant services, you can always reach me through my email address at nexsenpruet.com. I'll leave links to everything in the show notes below. Please continue staying safe and healthy. Practice safety for one and all during our collective life in the time of coronavirus. Thank you for listening in on today's episode, and I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday. If you want more information from me, go ahead and follow me on LinkedIn or send me an email at sonalpatel@nexsenpruet.com for all my consulting services in medical coding, auditing, and compliance. Thank you.